morning, everyone, and thank you for being with us today here. It has been a couple of years since we last met, so I'm very, very glad and very, very thankful for you guys all to come here today. What I'm going to talk about is just a little bit update about the Nebraska DHHS Healthcare-Associated Infection and Antimicrobial Resistance Program, which we call HAI-AR program. Let me see if the slides are coming okay here. Okay, so in terms of disclosures, I do have a funding from, let me see if I can go there, yeah. Funding from Merck for one of my research study, but I do not think there is any conflict of interest today with my talk. What I'm going to do today, I'm going to review a little bit trends in healthcare-associated infection and antimicrobial resistance in Nebraska, identify the opportunities that we have to improve infection control in the state and antibiotic stewardship, and then discuss some of the things that we are planning to do as we go forward in terms of providing the support that you guys need in strengthening your own programs. Now, let me start with what our structure is for HAI-AR program in the state. We have a very unique program, one of the very unique setup in the country, where we have a state and academia partnership. The state team has certain role that they fulfill. The academia team has certain role that they fulfill. And as you can see on the slide, the state team is involved in data, monitoring the data, running reports, or assisting with outbreak, initial outbreak response, and building partnership, working with you guys, policies, procedures, things like that. The academic team, the university-based team, is partnering with you guys to do infection control assessment, stewardship assessment, providing feedback on infection control and stewardship improvement in your programs, and connecting all the facilities with infection control and antibiotic stewardship experts in the field, which this kind of partnership then have given us access to. And then finally, development of educational guidance and resources that you guys all saw during the COVID-19 pandemic also. Now, this university-based team or academic team is divided into two parts: infection control assessment and promotion program called ICAP, and antimicrobial stewardship assessment and promotion program called ASAP. So how does it all fit into HAI-AR program for the state? You can see here in the organizational chart, I'm not going to go into detail, but you see two different colors in there. The blue color is more primarily based at the state health department. The red-orange color is primarily based at the academic center, where you can see the ICAP team under Kate Tyner there, and the ASAP team under Dr. Van Gunnefeld, and Andrew Watkins, who has moved on to a different role now in his home state, but we are filling that position. So that's the ASAP part, and then the ICAP part on the left, and then the state team on the right. But all of that is flowing all the way up to the HAI-AR program medical director, which is me right now. So that is the role that I accepted in the start of this year. So this is how the team is set up. The areas that we focus on in the HAI-AR program are huge. There are different variety. I listed some of them here: CAUTI, CLABSI, CDI, MRSA bloodstream infection, CPCREs, or other carbapenemous producing organism, any other organism that are relevant to healthcare-associated infection and antimicrobial resistance program, outbreak prevention and control, infection control assessment, stewardship assessment and feedbacks, education, training. Every single one of these areas are our focus areas, although we do prioritize them based on the data that we see. Where do we get our data from? So as you know, that healthcare-associated infections are reportable in Nebraska. And I put down some of the quotes from the regulation itself. So if you see in the regulation, healthcare-associated infections that are reported by healthcare facilities to the CDC NHSN are reportable to the state also. So most of the time when you are reporting it to the NHSN, you are conferring the right to the state health department so that we have the access simultaneously. If a facility have not conferred the right, then they are required to then manually report it to the DHHS. The best thing is to just confer the right. And then in terms of clusters, outbreaks, any unusual pattern you see, any increase from the baseline on a healthcare-associated infection, all of that are also reportable to the state. And one other thing that is reportable to the state is most of the positive culture results and their antimicrobial sensitivities. Those are also reportable to the state through the labs by electronic reporting. So we get that data also in our program. So I'm going to use some of that data that we get and give you an update on what we are seeing and what trends we are seeing. So starting with the central line associated bloodstream infection for the state, if you look at it here, what you see on the y-axis is a standardized infection ratio, or SIR, that the NHSN CDC defines for each facility based on looking into specific risk factors for those facilities, so how big they are, what kind of population they are serving, and they come up with a predicted number of infection that each facility will have. And if they go above that predicted number of infection, then their SIR goes up. And if the SIR goes up, that's a bad thing, meaning you are having more infection than you should. If you are seeing lower number of SIR, less than 1, then that means you are having less number of infection than what was predicted for you, which is better. So if you look into central line associated bloodstream infection, we have made progress over the years as a state. This is the data from ICU and ward from the hospital, and overall we are at a lower point than what we were in 2015 and 2016. So that's a good thing. When we look at CAUTI, catheter-associated urinary tract infection, what we saw was that we were doing much better back in 2018, 2019. We're still doing good. We're still doing good, but the numbers keep growing up a little. So just this year, 2022. We are about to cross the one that we have not crossed before. So this is an area where we probably want to continue our focus on. And maybe during the COVID-19 pandemic, the focus kind of shifted elsewhere, need to bring it back to the catheter-associated urinary tract infection. Now, we saw the same trend, if I go back, we saw the same trend on the central line also start to go up during the COVID-19 pandemic, but then starting to get better. Not seen that in the CAUTI yet. In the MRSA bloodstream infection, we have always done better than what was expected or predicted for us. In 2021, again, during the COVID-19 pandemic, it actually, I don't know why this slide is doing that, it went up a little, and then the SIR is starting to come back down this year. So hopefully that will go into the right direction there. In terms of C. difficile infections, we are continuing to do good. And that in the last few years, our program has been heavily focusing on the C. difficile infection reduction. And we have been working with many of you on ways to decrease the C. difficile infection in your facilities. We're focusing on antibiotic use overall the state. So all of that, I'm hoping has end up helping us to achieve the goals that we are seeing now, with the decreased rate. So keep the effort going. We are doing good. Keep the effort going on that. In terms of the surgical site infections, if you look at it, there are 2 surgical site infections that NHSN provide us the data for. One is for colon surgeries, and one is for abdominal hysterectomy. In terms of colon, the surgeries there, we have not done that good as we have done with other infections. We have always been a little above 1. This year looks like we are about to make progress, but although I have to see whether we continue to make that progress or not, because our up and down has been very obvious in that graph here. Now, going into abdominal hysterectomy, that's other surgical site infection that NHSN provides us the data for. We have really not been doing that great there. We have continued to increase now. In the last few years, we have at least plateaued, but we need to hopefully. Our goal should be to get this down a little more. So over the next couple of years, probably that will be our focus. So if you look at now overall picture, compare us with the nation in terms of where we are and where the rest of the nation are, you can see that Nebraska is doing better in many of the healthcare-associated infections, or as good as the nation. However, where we are not doing where we are not that great, or where we are lagging behind from the nation, is in the area of the colon surgery, the hysterectomy, surgery related to hysterectomies, and then the ventilator-associated events. Now, I didn't talk about ventilator-associated events that much because we do not get consistent data on the ventilator-associated events. It's not a requirement from the CMS. However, the data that I have seen is that in the last couple of years, we have done better than what it was in 2019 or 2020. So we're probably seeing some improvement there, although the data is incomplete. But the hysterectomy and colon, the surgical site infections are the one that should be our focus as we go forward, and we are putting our focus together. This year we have developed a subcommittee for surgical site infection, and this will be the subcommittee of Nebraska HAI-AR Advisory Council. Some of you actually sit in that council, and in that council we have been bringing some of the subject matter experts and some of the people who are focusing on surgical site infection to start looking into the big picture and maybe do some statewide surveys of protocols and procedure, establish some joint collaboratives where we work with each other to get to the same goal of decreasing our surgical site infections. There will be one-on-one outreach that we will provide in terms of an assistance that we'll provide as needed to the facilities with the higher SSI SIR. So that's in the plan. So you will be probably hearing from it and maybe even getting the surveys as we go forward. In terms of kind of pivoting towards antibiotic-resistant organisms, Nebraska has done better than the nation in that area. I picked up a couple of examples. If you look at on the left, cephalosporin-resistant E. coli isolate that have caused healthcare-associated infection. Now, these are not all the E. coli isolates that we see in general population. These are very highly specific groups of E. coli isolated, that are seen in the sicker patient that have developed healthcare-associated infections. In that E. coli isolates, the resistant organisms percentage is about, as you see, somewhere between 12 to 20%. Although we have been better than the national average, you can see there's slight upward trend there, if you can observe that, and in same way with the Nebraska. But overall, we have hold it, at a level there. Now, if you look at the carbapenem resistant among Klebsiella isolate, you can see that we have done better, also in there. But 2016, 2017, 2018, and 2019, we didn't have any healthcare associated infection related to a carbapenem resistant Klebsiella. However, in 2020, we started to see some of those carbapenem-resistant Klebsiella causing healthcare-associated infection, nearly close to the national average, which kinds of, is a signal for us to keep looking and be careful in that area. I hope that it went down this year or next year, but that is something that we are going to closely monitor, and we are going to work again on our antibiotic resistance pattern. That's one of the reasons we are having this summit together to build a program that can help us decrease these numbers. Now, if you look at, in general, all the electronic data that come to us from all the labs in the state, and so to look just the trend of carbapenem-resistant enterobacteriaceae, these are the organisms that we are most worried about because most of the antibiotics are gone in terms of treatment for these infections. So if you look at that, and these are from the labs that are consistently reporting to our electronic database. In 2021, we have seen a jump, as compared to the 2019 and 2020 isolate. Now, overall number of carbapenem-resistant enterobacteriaceae is still low. However, that jump concerns us. Now, again, it may be an unusual year, and maybe we will go down back again, and I hope we will. But that is something that we are continuing to watch, and probably next year we will give you some more update on that. In terms of another subgroup of carbapenem-resistant enterobacteriaceae, these are the ones that are producing a specific enzyme, carbapenemase. These carbapenemase enzymes sometimes can actually jump from bacteria to bacteria, so making it more concerning for us, and also spread very easily and cause outbreaks. So we are very, very concerned about carbapenemase producing enterobacteriaceae or enterobacterials now. And the good thing is that if you see 2019, 2020, 2021, and you go to the total column, the good thing is that at least these most concerning bacteria that we have seen a decrease from 2019 to 2020 to 2021, okay? And part of that is all of you doing all the right measures to prevent transmission of these resistant bacteria, putting people in the proper isolation precautions, making sure that you're working with the state health department on screening of the people around those positive people to make sure that there is no spread and containment of that. So I think that is one of the reasons that we are able to contain these organisms when we have identified these transmission. So for example, there are different genes that cause these carbapенemases, and if you see that, we have identified 30 of those isolates in 2019, 9 of that isolate in 2020, and 4 of them in 2021, and most of them have been the KPCs, which is the most widely resistant gene that we see in the US and in Nebraska also. And then in 2019, we saw some transmission through the NDM gene, but we have not seen that since then. And we saw some OXA 181 and OXA 48. I think maybe even a couple of them were just travel related, overseas related, that we didn't allow to transmit further in the state. And that is, again, success of the program that we have built and you have built together, in doing that. Part of that program is that when we identify a carbapenemase producing CRE, we alert you guys, we call you, we ask for containment strategy, isolation, we do investigation to see where else that patient has been, which other facilities, we alert them. We do screening, we do cultures, colonization cultures with screening cultures with rectal swabs, send it to the NPHL or ARL lab to make sure that if there are more patients that have gotten those same bugs, we can have them properly isolated and properly flagged in the system so that next time they come in, they are usually contained and proper precautions are being followed. There is one thing called antibiotic resistant information exchange, or ARIE. Some people have called it MDRO registry or XDRO registry. We don't have one in Nebraska. So right now in Nebraska, we have been relying on phone calls. So we find out there is a very super resistant drug resistant organism. We give you guys a call. You hear our call, and then you start making those changes or isolation precautions. And if person goes from facility A to facility B, usually we are working behind the scene to alert. But those are manual processes, and there are chances of failure in them. We are working our best right now to work with the Sync Health to identify a short-term and a long-term solution of having some kind of a flag or some kind of a chart that can alert you, even if you are nursing home resident, nursing home infection control leaders, and you are admitting a patient from a hospital, if they have a history of this kind of an organism, that you can be alerted, not just relying on the phone call, but through some kind of a chart system or some kind of a registry where you can go and check. And that is something that we are in the process of building. We have put up a committee also for that, and we are in negotiation with the Sync Health to find the best solution for that. So we'll provide, hopefully, some good updates in the months to come, or hopefully next year when we meet, we have a solution already figured out. Pivoting to antibiotic prescribing, because we're talking about drug resistance, how does that happen related to antibiotic prescribing patterns? Dr. Kabani also showed it, this graph, I think, and you can see the Nebraska red. Nebraska red probably, is something that we see all the time, but this is not a good place to see Nebraska that much red here. We want it to be a little bit less, maybe a different color, maybe white. So in terms of that, what it means is that in community, we are prescribing more antibiotics than our national average, okay? Probably the most among all the states that we are seeing, or towards the top. Now, the good thing is that, it's not all bad, the good thing is that we have worked over the last few years, and we have been able to decrease our antibiotic prescribing. So for what it was in 2019 to what it was in 2020, it has come down, and I'm hoping that it continue to go down. But the nation has also done improvement. So everybody is trying to focus on that. We still have a lot of room to grow in the community prescribing. We are brainstorming right now on ways to do that, and hopefully you guys are brainstorming in your own facilities on how to get there. The good thing is that, and this is based on this data here, Dr. Kabani was talking about the SAR, the Standardized Antibiotic Administration Ratio. This is what it is showing here. And this is from the hospitals that are reporting their data to NHSN antibiotic use module. If you look at that data, at least we can see that in the hospitals that are reporting to the NHSN, which are few, we have done little better, maybe about the same as a nation, but maybe even a little better in terms of our antibiotic prescribing. So even though in communities we're still high prescribing pattern, in the hospitals we have been able to cut it down, to the level where we are around the national average or better. But then again, this is those hospitals that are actively participating into the AU-AR module, and they probably have better, well-financed antibiotic stewardship programs. There are other hospitals that may not have that resources. They may not be doing this good. We don't have the visualization there. So what do we need to do? We need to have more hospitals join our AUR, NHSN AUR module, so that they can see the data themselves and they can improve on it. And I'm going to talk about what we are doing about that in a second. But another area that we have done better over the years is so there are a number of hospitals that report annually to CDC through NHSN on how many core elements they have already implemented. And if you see the number of hospitals that are reporting at least to the CDC on that they have done some core element, have been increasing over the period of time. And the dark blue shows you what proportion of the hospitals that are reporting to have all 7 core elements in place. So about 78 hospitals have reported in 2020 in the NHSN module, and out of those 78, 90% of them has said that they have implemented all 7 core elements. So that's great. We are making progress. Now, I will say a caution, if a facility is doing all 7 core elements, it doesn't mean that they are doing the same way as some other facility who are doing the 7 core element. There's actually a different aspect of those core elements that can have more impact versus less impact. So they are not all similar. So for example, I'm going to go here in leadership. Every one of the core element is leadership commitment, and many hospitals are saying that they have the leadership commitment. Now, within the leadership commitment, how do you find that you have leadership commitment? You can have IT resources that many of our hospitals said that they have at the level of the national average, but then there are hospitals that says, that are lagging behind in having physician on the contract to help with the stewardship, having pharmacists on the contract to help with the stewardship. That areas are lagging, even though we are saying that we have IT dedicated to do some of the stewardship, but the leaders like physicians and pharmacists, we are lagging behind there. So even though they will be counted as having that leadership commitment met, but the impact may not be the same. So we need to kind of get that high also to get our pharmacists, our physician involved in antibiotic stewardship more. What are we doing for improving antibiotic stewardship programs? One of the biggest things that I will say that I'm very looking forward to is promoting the use of NHSN antibiotic, antimicrobial use and resistance module, the AUR module in NHSN. It is an expensive process, so many of the hospitals may be thinking about it but not going forward because it is expensive. We have secured at least some funding for some partial cost reimbursement programs. So basically, what we are going to try to do is kind of the proposal is that if some hospitals put some money towards it, we can do some money from our side, from the state, and get them moving forward to have them set up for this module. How is it going to happen? The detail is going to come later on, but we are working towards it. We have secured some funding already, and we are going to make a proposal soon. Other things that we are doing is, we are going to try to have some kind of a wall of honor or something like that for recognition of facilities that have meet all the antibiotic stewardship core elements. How we do that is still in debate, but we are going to work on that. We have the free antibiotic stewardship program assessments and feedback. Any one of you can ask for a free assessment, non-regulatory, peer-to-peer feedback from the ASAP program, and they can get it and they can get good recommendation on how to improve it. We are also thinking about for the nursing homes to have collaboration with the long-term care consultant pharmacists to focus on deriving some practices that can help nursing homes. Again, that's a process in development. It's in planning phase. We'll come to that. And then sharing data with healthcare facilities at the local health department level is another thing that we want to do, like developing local health department related antibiograms. So you know what your antibiogram in your own communities are. We're working towards it. We have a draft ready, just process of validating them. Hopefully sometime soon we will have that also. Another thing that we have available on our website now for you in terms of the local health department jurisdictions is our C. diff rates in Nebraska. So if you go to this website and go this is very interactive. You will go there, you click around your mouse, and it will show you everything on that level. What is the trend of the CDI rates? Now at this point you look at it, you will see that a certain part of the state has much higher CDI rate per 100,000 population than other part of the rate, and it is different from jurisdiction to jurisdiction, kind of giving you information that you can utilize for messaging and for making improvement in your own jurisdiction. So this is live. This you can go even today and try to look at what is going on in your jurisdiction. In terms of long-term care facility support that we have done, kind of going into a different topic here, during the COVID-19 pandemic, we have been heavily involved with the long-term care facilities, and you can see from March 2020 to July 2022, we have assisted 425 of 489, about 86%, 87% of Nebraska long-term care facilities with their outbreak. We've almost almost 80-90% of the outbreak we have assisted one-on-one in some capacity to the long-term care facilities, which there is a need, and we appreciate the collaboration. We know that you appreciate our help, and we appreciate your collaboration on that. We have held the weekly webinars, and we have our attendance always have been somewhere in 200 to 300s, and sometimes even 400-500. And on top of that, our ASAP program has assisted with the review and distribution of more than 1,600 COVID-19 treatment courses throughout this pandemic. We made it a priority that every single nursing home resident from the day one that monoclonal antibody was approved, that we will have the treatment available for each and every resident of a long-term care facility in Nebraska. And I think we have never refused someone who met the criteria and needed the thing, and we were able to arrange it. So I think all of those things are great. We are proud, and I think you are proud of all the work that you have done, that has shown up, correct? We have the 7th, if you compare all the states in the country, we are one of the 7th lowest case rates among residents of long-term care facilities that have COVID-19. So we are among the lowest case rates in the country for long-term care residents. And if you look at the death rates, we are also the 7th lowest death rate in the country among nursing home residents due to COVID-19. So, all the work, and you can see some of the orange ones are our neighboring states. So all the work that you guys have put together, working collaboratively, has been able to achieve and have enhanced the patient safety and the resident safety in Nebraska. Now we are going to be, and I'm very excited to announce this, we are going to be even expanding our infection prevention control support to Nebraska long-term care facilities. We are actually working on a long-term care facility strike team project. What is that project? That project includes training a few long-term care facility staff in each facility on performing N95 fit testing, providing the equipment for fit testing to each long-term, and I'm talking assisted living also, assisted living facility too, provision of the fit testing equipment, facilitating additional training for infection preventionists, additional training for infection control champions, and all of that, while doing all of that, giving some reimbursement for the time spent in doing all of those things. So we have secured funding. We probably cannot have 100% reimbursement, but we'll have as much as we can to provide. So if you train an infection preventionist, you will be able to get some cost reimbursement of the hours spent to take that training, of the mileage that they have to drive to get that training, of the course fees that they have to pay to get that training. We will be able to support some of those things for the long-term care facilities as we go forward. So, that's something that is in the work, and we will have details announced soon, but I just wanted to make sure everybody knows that this is coming. And then we will have additional training opportunities also for the long-term care facilities. Other things that are in the works, the voluntary free infection control assessments for all healthcare settings upon the request, an infection preventionist mentoring program, individualized infection prevention control training courses for healthcare facilities, everything. I'm not going to go into detail. You guys know most of these things, and our booth is out there if you want to get some information on that. There are many different ways to contact us. You can contact us in any way possible. There are different ways to reach out to us and make it very, very easy. So final thoughts, in many areas, Nebraska has done better or similar to the national average. However, there are areas where we need to work more, and the best thing is we work collaboratively, and that has helped us in achieving our goal. There are certain areas where we need to collect additional data, and we will work with you to identify those ways where we can collect those data so that we can bring it back to you and use it for improvement as we have done so far. So thank you very much. Really appreciate everyone being here.